Lynch, who will be presenting on the evolution of the Hamilton's Public Health Quit Smoking Clinic. But before I hand it off to our presenter, I'm just going to go over a few housekeeping slides as per usual. So if you are interested in obtaining a letter of completion for this month's Teach Educational Round, please make sure that you have registered for this webinar and completed the pre-learning assessment. You have signed in to view this webinar using your first and last name so we can track your participation. And finally, you complete the evaluation and post-learning assessment, which will be emailed to you this afternoon, and you'll have 1 week to complete that. These webinars are being live tweeted on Twitter, and you can follow us at PSQuitSmoking or use the hashtag TeachWebinar to post or read questions. Here's a biography of our faculty presenter, Megan Lynch, who is a public health nurse with the City of Hamilton's Tobacco Control Program. She has been systemizing best practices in tobacco dependence in healthcare and community organizations and providing intensive tobacco cessation counseling for 10 years. Megan successfully defended her thesis, Minimal Contact Interventions for Tobacco Dependence, to attain her Master of Education and has completed the requirements to become a certified tobacco educator. Megan's passions include public health evidence-informed practice and program evaluation. Thank you, Megan. Welcome. Here are a list of her disclosures. Just note that she is a Stop for Addiction agency site since 2015. This is a friendly reminder that the content of Teach Educational Rounds is primarily based on evidence-based guidelines from the following sources. These materials, as well as the verbal presentation and any discussions, set out only general principles, and they do not replace the need for individualized clinical treatment plans by healthcare providers. So I'm just going to do a few polling questions to gauge who has joined us here today. So in a minute, using your computer, could you please indicate which of the following organizations you work for? And if your organization isn't here, you can always type it in the chat box. So we're seeing lots of public health units come up. Some family health teams, community health centers, mental health agencies. Great, thank you. And Dan Edwards, thank you. Megan is awesome. And can we also get individuals to indicate their current discipline? And you may just need to scroll down to see all options. So we have some registered nurses, health promoters, SSW, behavioral therapists, great. And finally, could you please indicate which region your organization serves? And if you do work out of province, can you please type that in the chat box as well? Manitoba, okay. And we're having Toronto and Greater Area come up, some Central West area, Eastern area, great. Okay, thank you everyone, and I'll leave it to Megan to take away.
Sure, thank you very much. So today's learning objectives are really to explain what we do at our public health clinic. We're lucky because we're a public health clinic as well as a Stop for Addiction agency, and really to identify some of the outcomes that come from our group and individual settings with respect to tobacco cessation interventions, and really why probably most of you are here of what can you use from us and really discuss how our clinic was developed and how it can be adapted to other local settings. So first of all, thank you very much for coming here and joining us to listen, but also thank you to my team. I work with 2 other public health nurses. We're a great team. We have lots of support from our managers, our associate medical officers of health, and definitely from CAMH as well. So a little bit about the City of Hamilton for those of you that don't know. We are about 580,000 people. We're located about 60 kilometers southwest of Toronto, and we're considered a port city on the western tip of Lake Ontario. It's divided, the Niagara Escarpment is divided with a huge forested area, and a lot of us locals call it the mountain, which is dotted with conservation areas and waterfalls. The Bruce Trail runs through here. It's known for its industrial city and nicknamed Steel Town because of many steel manufacturing companies. It's home of McMaster University, Redeemer University College, and Mohawk College. And so in Hamilton, working for public health, we're really lucky that we get to work together with our epidemiologists. They're constantly providing us data with local trends with respect to tobacco use and tobacco cessation. And that's how we know, and we measure and monitor local trends, and we use that for our planning and programming. And so about 19.1% of Hamilton smokes, or 1 in 5, and that's above the provincial average. And we have especially higher rates in certain subpopulations. So really the history of our clinic, and I'll try to make this as clear as possible because it's been 11 years since we started and it's definitely morphed along the way. So looking at our local data, again from our epidemiologists, we knew that there was gaps in services, there was many priority populations not receiving tobacco cessation services, and public health began a clinic. We used one of our sexual health and dental clinics that wasn't being used one morning a week, and we started our clinic. We had municipal funding, about $15,000 a year, to purchase nicotine replacement therapy, and we offered a clinic half a day a week. So really the purpose of our clinic at that point, and still continues to be, to provide intensive smoking cessation counseling by a public health nurse to populations that aren't served through existing programs. So we looked at the local data and we knew it was going well. We were seeing lots of clients, so we had the capacity to expand, and we opened up 2 additional sites. We kept our East End clinic out of the sexual health clinic. We expanded downtown. We partnered with our alcohol, drug, and gambling services, and then we located a 3rd clinic on the mountain, so through our Lime Ridge Mall, because we knew that was one of the subpopulations that had a higher smoking rate, working in retail, knowing that a lot more families were partnering there, and opened that up. So again, we constantly use our epidemiologists doing evaluations, and we realized for the amount of staff time to spread ourselves between 3 half-day clinics throughout the city, we looked at the postal codes of many of our clients, and we decided to expand our downtown clinic within alcohol, drug, and gambling and really focus very strongly on them. Also at that time, we had a new medical officer of health on board, very focused, very dedicated, understood what we were trying to do with our tobacco cessation interventions, and we were able to expand our medical directive. So we went from being 8 weeks on label, giving out patches to these clients, to a really expanded medical directive that included pregnant and breastfeeding women. So we were able to give out nicotine replacement therapy off-label to this population. We also, at this time, we're spending more time on looking at what else was happening in the province. We were interested in the Ottawa Heart Model. We were interested in what CAMH was doing and other health units and clinics. And from then, we expanded to have a prenatal incentive program, really focusing on this population that we knew had a high smoking rate in Hamilton, but they previously had not been attending our clinic. And I'll talk more about that incentive program in a little bit. And then from there, what happened is we expanded, our office moved, and we were doing well. We were kind of above capacity within our current clinic, so we opened up a 2nd clinic in the downtown site in the new McMaster building, but it never took off the same way that our other downtown clinic had. And really, I think we learned from that is clients need to be felt comfortable in the clinic space. It was an office space that we tried to operate our clinic. So around 2017, our McMaster clinic really kind of evolved and became a newcomer outreach clinic. As we slowly shut down that McMaster clinic, it became newcomer, and I'll speak to that more of what that is. And our alcohol, drug, and gambling clinic, at that point, we became a stop site. So each year we were getting municipal funding or one-time funding from the ministry to purchase NRT and continue our program that way. In 2015, when we became a stop site, we no longer had to worry about purchase agreements and procurement and where are we going to get the NRT from. And we were able to partner with STOP to have all of their support as well for our clinic. And really it became a transition of having 2 nurses, dedicated full-day clinic on Mondays, and then an outreach clinic to our newcomer and immigrants with language support 1 or 3 times a month. So going from 2008 when we started, it was really an on-label 8-week program. The client came in, they wanted to quit. We expected them to have a quit date. They picked their quit date. We gave them the patch, and we needed them to come back every single week. They would attend for a 30-minute appointment. We use cognitive behavioral therapy as well as motivational interviewing. And it was a very intense clinic. I don't know how client-focused it ended up being. Clients were very appreciative of the support, but there wasn't a lot of leeway for what we're now seeing where clients aren't able to attend every single week. They fall off the wagon. They need to come back. And then from then, we did have an expanded medical directive. So we're able to give more than 8 weeks of nicotine replacement therapy. We're really looking at a combination therapy to give the patch as well as short-acting. We're able to better support breastfeeding pregnant women with nicotine replacement therapy as well as incentives. Our clinic expanded to 16 and over instead of 18 and over, and there was an undefined length of treatment. So if somebody needed to be on the patch more than 8 weeks, we kept working with them. And then through time, we realized some of these people would try to be on nicotine replacement therapy for longer, and even if that meant years. So we really had to define when it was an appropriate time to cut them off nicotine replacement therapy if they were no longer meeting goals. And then in 2015, we became a Stop for Addiction agency site as we are working out of alcohol, drug, and gambling. We are already at an addiction site operating our clinic. Again, our medical directive continued to expand and include more populations and more ability for us to dispense as we are registered nurses working in the clinic. And the benefit of this is also the data collection. So we had been previously taking a baseline information of the clients at intake. It was all paper chart, it was all paper copies. Nothing was really done with it until every 2 or 3 years when we did a clinic evaluation, and we'd have to manually go through and pull data and find information. And really the intake purpose at that time was to see if they're medically able to use nicotine replacement therapy. And now as a Stop for AA site, we really are able to focus better on the populations we're serving and the things that we need to do to support them. And we do have the ability that if they had been successful and they meet the eligibility criteria, they can re-enroll after 12 months if they need more service. So trying to break all that down to what it really looks like when we're at clinic on a Monday, I've kind of created a chart. So the client will call, or there can be a healthcare provider call or fax a referral into our clinic. We receive about 900 to 1,100 referrals or calls per year. And once that contact's made, they're automatically booked into a 1-hour group session. What we were learning previously from our clinic is if they were put on a wait list or they at that first contact weren't given an appointment, they were less likely to show up. So we did realize it's less administrative work on our time if they're given an appointment at that first contact. And it's also works better for our healthcare providers and our referral sites if they know, okay, their client's going to get seen usually within 2 to 3 weeks of that referral, and that's what they can be telling their client or their patient. At that 1-hour appointment, we schedule up to 20 people based on room capacity. We do bring administrative support to come along with us, and they help with data entry of all the registration and intake forms. We do a presentation, so we do a very informal presentation with the group, and we talk about quit planning and coping strategies and triggers. We go through all the nicotine replacement therapy, the proper ways to use it, monitoring nicotine withdrawal and nicotine toxicity, and then we schedule their next appointment. And the default from there is really to keep scheduling them into a group. We began groups around 2016 knowing that it was a better use of our time. When we were giving everyone an individual appointment, if they did not show up, then the nurse was sitting there for half an hour waiting for the next appointment. If in a group setting, if 3 or 4 people don't show up, you're still seeing 6 to 12 other people, and it's a good use of your time, as well as the client knows, okay, if I've been sick, I've been hospitalized, I missed an appointment, I can return to clinic, and I know that they operate 10 a.m. groups or 2 p.m. groups. After our group intake session, if a client is more complicated, requests extra support, has a language or cognitive barrier, or just we feel that they would benefit, we do offer them an individual 30-minute appointment instead of booking them back into group. The subsequent groups, we usually talk about a modifiable risk factor on top of tobacco cessation as well as nicotine replacement therapy. So this week we talked about sleep and how that relates to tobacco cessation. Previous weeks we've also talked about healthy eating, weight gain, coping strategies, setting a quit date, meeting your goals. If a client is unable to attend a group intake session based on their schedule, or again, other reasons why we'd be offering individual sessions, we book them a one-time individual appointment, and then from then they just continue to get follow-up calls. So our clinic really is individual as well as group appointments. And then a separate program that we're operating within the STOP site at clinic is also for pregnant and breastfeeding clients. So these are always booked into individual appointments. On top of that, they receive a $10 grocery card, gift card for attending. We do have bus tickets. And on subsequent visits, if they're able to demonstrate a reduction in cigarettes, 24 hours smoke-free, and a carbon monoxide breath test of less than 7 parts per million, they get a second gift card. So they can get up to $150 worth of gift cards, recognizing that this is a very important time in their pregnancy and to quit smoking. We're trying to support any other barriers that could be happening at that time. So for those of you who are not aware of what STOP sites look like, so they're STOP for family health teams, addiction agencies, community health centers, and nurse practitioner-led clinics. There's many benefits of doing this, and like I said, not just because we no longer have to work with our finance department for procurement and policies of nicotine replacement therapy. So each client is provided up to 26 weeks of nicotine replacement therapy combination, so they can get patch, gum, lozenge, and inhaler. There's also data collection through their registration and baseline. There's an online portal to track all of this. Previously, we had been using a very ancient method of Excel, Outlook, and hand counting all of this information. Being a STOP site, we also get the support from all of CAMH staff and the online community. There's bi-weekly teleconferences. And then also we have the follow-up surveys for clients. So this was one of our biggest struggles previously when we started the clinic in 2008, is really monitor how we're doing and how to follow up with these clients in the most efficient and effective way. So currently as a STOP site, clients get emailed at 3 months and then emailed or called at 6 and 12 months to track their progress and see if they have stopped smoking. So a little bit of kind of how the clinic runs on a day-to-day. If they're given an individual appointment, it's anywhere from 15 to 30 minutes. If they're attending a group session, it's 1 hour, and we always book it at 10 a.m. and 2 p.m. Our clinic is only on Mondays, so clients know. They receive up to 26 weeks of nicotine replacement therapy within that 12-month period. They're always given behavioral support with a focus on motivational interviewing. There's usually a health topic and proper use of nicotine replacement therapy. We have administrative support to make sure we do appointment reminder calls for every client. So they're called the Friday before to remind them of their clinic appointment, remind them of where the address is. And this year we've just implemented also having staff do a 3-month follow-up call because our clients are emailed that, and we're finding not all of our clients have an email, use computers, or want to provide that. And when our staff does try to complete the survey on the phone with these clients, we try to re-engage them and offer for them to resume clinic appointments. And we really try to be as flexible as possible. So if somebody's been attending 2 p.m. group and they've just kind of dropped off the wagon, we haven't heard from them, if they show up, we try to see them as best we can. We try to make as many exceptions as we can. We do get to a point where everyone's making an exception, and if we've booked 40 appointments on a Monday and everyone's showing up at a different time, it does make it very tricky for us. But we're trying to be very reasonable and flexible with them. All of the clients are given a business card, appointment card, after when they leave clinic, and it reminds them of when their next appointment is, where it is, what time, and then we also give them our secretary's phone number to call and reschedule if need be. We do provide quit kits. On one of our clinic evaluations, we found it's best not to provide them universally. We've started to provide them on an individual base, and usually what that is whatever funding money we have left over at the end of the year, we go to the dollar store and purchase craft and art supplies, word books, crosswords, word finds, Sudoku books. We've purchased fidget toys, stress balls, anything to keep them busy and to be doing instead of smoking, helping them, give them some ideas of what they can do instead. Another thing that we've implemented is kind of a certificate. We were finding some of our clients were getting very overwhelmed with the thought of going from smoker to non-smoker and really piecing it out with kind of a week-by-week setting a goal, meeting a goal, and focusing on that. The other thing that this certificate does, it was a really nice celebratory way to end that relationship. If we saw someone every 1 to 2 weeks for 26 weeks, they got very attached to myself or the other nurses, and they wanted to keep attending. So it was a great way to kind of celebrate their graduation, talk about relapse prevention, especially when we present it within groups, then other people who are beginning their journey can see what success looks like. And sometimes after the 26 weeks, if they haven't, if they're not completely smoke-free, but they've met some of the goals, we'll still give it to them and remind them to keep trying. So a little bit about where our clients are located in Hamilton. So again, we have over 500,000 people in Hamilton. And this is a little bit misleading because it's actually the postal codes of all of our clients that have attended clinic and not where smokers are located in Hamilton, though it does very much match where we are. And this graph, this map does show that our clinic's pretty centrally located, based on where most people are coming. And because we are located downtown, we're on many, many bus routes, and we're in a pretty central location of where we are. To note, Hamilton is really lucky. We do have 9 organizations within Hamilton that are stop sites, and of them, there's over 20 sites within Hamilton. So if they're part of a rostered patient from some of the family health teams or community health centers, they're able to get the stop program through them as well. So where our clients are actually coming from are clinic referrals. In public health, we're very lucky that we have an internal policy, and that requires all of our staff with client interactions to perform brief intervention and offer a referral. We have moved over to an opt-out approach where they are performing the 3 A's with their patient and offering a referral to our Quit Smoking Clinic. And it used to be Smokers Helpline, now it will be telehealth as well. And unless the client does decline. So it's the default would be to offer a referral unless the client does decline. In Hamilton, we have a very active community of practice of all providers that work in tobacco cessation or have a passion for tobacco cessation, with over 100 members, and they're all aware of our services. They're more than welcome to refer their patients and clients. We give them promotional materials. We also give them fax referral forms, so if they're in their own clinic or site, and they can fax a referral off for us. Because we are public health and we're not just doing clinical services, we do spend a lot of time with health promotion and education. We provide healthcare provider training on brief interventions and how to make a referral to our site, the other stop sites, as well as telehealth and Smokers Helpline. Our clinic does have a tobacco hotline. Clients can self-refer. We're promoted within our public health website. We're on the Quit map, and then Hamilton's Care Pathway, our community practice, also has a website to find out more. So these numbers are a little bit tricky because we've had multiple sites. So I've tried to track the multiple sites, and then in 2015, so the next slide, we did become a Stop for Addiction agency. But really what I wanted to highlight here was when we started with our first clinic, we were seeing a very low number of visits, but our staff was at the site for half a day a week. 2009, we were at 3 sites for half a day a week, and really the clients did enroll, the visits did increase, but it wasn't until we really focused on being at one site and putting just as much time into that one site, but really expanding how we were doing clinic, that we were able to enroll more clients and offer more visits within those clients. So our next one, so Stop for Addiction agency has always been the same. Our McMaster clinic did start as a regular downtown clinic, and then in 2017, it transferred over to be an outreach clinic for newcomers and immigrants. But the data is all together, so it's a little bit of a mix to see that, and we'll see that in some of our outcome slides. But really what it shows is that we're able to see over 300 patients within our one-day-a-week clinic. We only have 2 nurses staffed there, sometimes only 1, and we're able to offer about 1,300 visits. In 2019, the data I stopped, I think October 31st, but really we're on track to be the same as 2018 or possibly even more. So our clients, we are focusing on those that would not have tobacco cessation services elsewhere, but we're also, again, working with our epidemiologists to see who has the higher smoking rate, who would benefit the most from these interventions, and how we can target them. So we target with promotion to these populations, but also working with the healthcare providers to make sure that they're aware that we offer these services. And really focusing on individuals without a family doctor. In Hamilton, we have 2 very large family health teams that are also stop sites. So really Hamilton's one of those lucky cities where if you're a tobacco user, it's a very good chance that you can find services. And then so a little bit about our pregnant and breastfeeding program. So this is the incentive program that we adopted from another health unit. I think they presented at Ottawa Heart about 5 years ago, and we liked what they were doing in their research, and we were able to start it as well. And so in the beginning, I believe they were unfortunately tracking partners as well as pregnant clients. So again, our data is only as good as our data collection tools, and until 2015 when we had CAMH to help us with that, we definitely saw a huge increase in the data we were able to collect. But really, we are seeing clients, they are coming, but they're not coming at the same rate as our non-pregnant clients. So we're exploring better ways to focus and help this population with tobacco cessation. And then so looking at our data from 2015 on, when we became a Stop for AA site, we can really look at who's the population that we're seeing and what's going on. And so not surprisingly, we're at an alcohol, drug, and gambling site. We are seeing many people who do use alcohol. And the McMaster site, I'm just going to note that in 2017, when it became the newcomer site, not all the baseline data was collected, and that's due to language support and having an interpreter for all the questions. So some questions did become omitted with permission. And then so again, looking at past marijuana use of our population and past opioid use within our population, it's a little bit higher than the other addiction agency sites, but pretty much on track. And then the 2019 data, we only collected for the first 3 quarters, so until September 30th. And then so we also noticed that the question here, is have you received treatment for mental health in the last 30 days, or have you received treatment for substance use treatment in the last 30 days? And looking at these stats, but also a great thing about this data that we're collecting and these questions we're asking, and as well as working in addiction agency, is if they haven't and we know they're indicating alcohol, substance, or other use, we're able to provide that referral in that support. Our social workers are great partnering with us, and as well as when they're seeing their patients and they're indicating that they are tobacco users, it's really easy for them to say, you're going to come back here on a Monday and you're going to be enrolled in this and receive free nicotine replacement therapy. So other baseline data, really looking at our priority populations and those living in low income. We know from our baseline data that more than 50% of them are on the Ontario drug benefit. And we're also looking at other populations and seeing if they're identifying as First Nations, Indigenous, or Métis. And then another thing that we always want to look at is, are we receiving the appropriate referrals? Are we partnering well? And how healthy or unhealthy are our clients, and what else we can be doing. So this slide is just comparing our site, so ADGS, to all addiction agencies based on the baseline data, and really looking at that. And then we've noticed since a few of our partnering stop sites within Hamilton do focus on those with a mental illness, we've been able to refer clients to that stop site instead of seeing them ourselves. So our number there is below other addiction agencies, just because we found that it was a better tailored service for our patients as opposed to seeing them ourselves. So looking at outcomes, so this is some qualitative data of what we've looked at through past clinic evaluations with our epidemiologist supports and what's going on, is when we had our 8-week on-label nicotine replacement therapy clinic, clients were coming on average 2.1 visits. When our medical directive expanded, we were able to offer combination therapy or 26 weeks of nicotine replacement therapy. It doubled. So clients were visiting up to 4.2 times. Of note, some of those clients might be receiving 4 weeks of nicotine replacement therapy at a time instead of one. So it could actually be quadrupled and not just doubled. When our clinic operated on a wait list, so a client would call, we'd wait for the next individual appointment for them. We did not do group intake. We had clients, about less than half of clients would attend their first appointment. I can tell you anecdotally from our admin support that had to call and trace down these clients 2 to 3 months later after that referral. Numbers were out of services, clients were no longer available, or clients had went elsewhere. And so this ended up being a large amount of administrative time to kind of maintain this wait list and as well as find those clients afterwards. When we went to a group intake where we knew every single month when we would have new clients come, we had about 70% of our clients attend that first appointment and a huge reduction in administrative time in order to schedule that. And then so when we went from down to our one main site, which is alcohol, drug, and gambling, from our 3 half-day sites, we were able to increase the amount of appointments available. We decreased the amount of no-shows, and it was a lot more efficient for staff. We didn't have staff driving all over the city, as well as lugging all the nicotine replacement therapy and other supplies within the city. And then we also know from our prenatal incentive program, which is nicotine replacement therapy, gift cards, and bus tickets, we've seen an increase in attendance and follow-up visits, but really it went from like a 70% no-show rate to 50%, and clients attending one time to clients now attend 1.8 on average. So it hasn't been a huge increase. It's a small win, but we know that we need to keep working on that. Okay, so the purple is our previous model of individual appointments only. Every client was getting a 30-minute appointment. And then the teal on the right is our group intake and our group appointments. So we're really able, like what I want you to get from this slide is we're able to see about 50, maybe up to 150 clients per year. And now we're seeing over 300 clients per year. And it really isn't that much more staff time. So one staff was traveling to 3 half-day clinics, so we'll say 1.5 a week, and now we're up to 2 staff are at clinic 1 day a week. So it's not a lot more staff time. There's no driving around, so really it might be less staff time in order to see more people. We're only booking 6 to 12 people per clinic, and quite often, especially if it was a snow day or something else going on in the year, a lot of them were not showing. So we're paying for staff to sit at a clinic for half a day and not see people. Now we're able to book 20 to 40 people in a day. 2 of those are group sessions. The rest are individual appointments. Clients are saying that they're more satisfied with the service that they're getting, and we're able to offer a lot more visits. So even though we're seeing more clients, I think we're also seeing clients more often as well. So what most statisticians want to know, and if you really want that quantitative data, so is it working for our clients? Based on our quit stats at 12 months from the clients that answer their email or their phone call when they're followed up, their 7-day point preference quit rate is higher than most of the addiction agencies within Ontario, except for 2016 when we were just starting up. And that might have been that we weren't providing the best care that we could have done. We feel like we've kept looking at the data, asking the clients, and really modified what's going to work and how we're going to see patients the best way. Hopefully this is clear. So I'm going to talk about the group of graphs on the left, our ADGS client. What we are noticing from clients attending a second appointment versus coming one time only was that when we gave nicotine replacement therapy on their first visit, especially because they were told that that was what was going to happen, and in Hamilton we have a lot of pilots where they will receive nicotine replacement therapy out in the community or from the hospital at discharge, they're expecting that nicotine on their first visit, and they have probably been on nicotine replacement therapy for a couple weeks already. So we do know that having them receive it at their first visit increases the likelihood of them attending more appointments. And so 2019, we're on track that they're getting on average about 11 weeks of nicotine replacement therapy per quit session, so per 20 weeks, so per time coming to see us. And then the graphs on the right, the McMaster Clinic, 2016 and 2015 and 16 are when we were our second downtown site, and then the other is morphing into our newcomer Aboriginal site, newcomer immigrant site, which is very similar to what we're seeing at our main clinic. So other things, some more qualitative data that we can look at really is having people make that quit attempt, having them feel comfortable when they come and see us, knowing that they can get service, knowing that if they've been discharged from a heart attack or stroke in the hospital, they spoke to their nurse or their social worker and they're getting a referral to us, that they know what to expect. We do a lot of communication with those staff. There's very strong partnerships, and we really just want them to come and try. So we do really focus on making that quit attempt versus looking at the overall quit rates. And we are finding that this is helping our overall quit rate by me being more flexible and really looking at that. We are spending more time talking about coping strategies and other ways to deal with stress and other triggers instead of just smoking. And I feel like we're in a great position working within an alcohol and drug and gambling, like addiction site, to provide services for other treatment. And really, since previous, the Teach Education rounds earlier this year by Dr. Salvi that talked about optimizing tobacco cessation services, we've started implementing a lot of that. We are seeing client attending more. We're able to get those clients to that quit that previous years they might have still smoked 1 or 2 for the full 26 weeks. So really for us, it's about looking at the data constantly and making small adjustments constantly, but also kind of monitoring what's going on as we go. Okay, so our third objective today is what can you take from what we've done, what we've learned over 11 years of clinic, and really apply it, whether or not you're a public health unit or a stop site or would like to be one. So, looking at clinic logistics. So we have 2 staff that attend our clinic. They're both teach-trained public health nurses. We have a third staff that's trained. She covers all our vacation or sick time, and we just make sure that we're always able to keep operating at the same level. We do work under a medical directive for off-label use for anyone 12 to 18, pregnant or breastfeeding, and a few other caveats. And I'm more than willing to share a medical directive with those who are interested. We also have a medical officer of health, or associate medical officer of health, who's a doctor. He's on call and available for consults, email, or phone. We found the best thing with our clinic was to operate within an existing clinic. We have reception and administrative support. People know where they are, and it's already kind of a base of clients to work with. We're able to partner with the social workers and get referrals, but also use them for referrals. Nicotine replacement therapy, we definitely know that if you have it, they will come. Previously, we had spent about $30,000 a year on nicotine replacement therapy for our clinic, and now we're able to get all of that through CAMH, which is Ministry of Health and Long-Term Care funded. And then we know a clinic needs to be promoted. The better you promote it, the better they'll know about it and continue to come. And then so really looking at how are your clients going to hear about you? And so for us, it is a lot is the healthcare provider training, making sure they know what we do, who we are, and that's healthcare providers within Hamilton as well as in our own internal clinics. And so for some of them, we'll go out, we'll do a lunch and learn, we'll provide lunch, we'll do their brief intervention training, we'll give them referrals to our clinic as well as telehealth, and we'll make sure that they know that it's a very brief intervention and that they can do it. We have also partnered and worked with other organizations as well as internally to have a policy that all healthcare providers are doing brief intervention and that they're making referrals. Internally, we do an audit every year, make sure our clinical staff is still doing it because we feel that it's really important to walk the talk and that if we're going out and telling other healthcare providers that they need to be doing this, that we also should be doing it internally. And then we're constantly promoting, whether it's Quit and Wins or doing internal promotion using Twitter, our websites, and making sure people know who we are and what we do. And then another big thing for us is monitoring. So we do monitor all of our client referrals and where they're coming from. And we look time of year as well. And if we had been receiving 200 referrals from a certain organization and all of a sudden it falls off, we wonder what happened. Sometimes it's a staff change or a process change on their end, so we make sure that we're looking at that. We're also looking at clients attended. So if we're getting 1,000 referrals a year and we're only seeing 200 clients, what's going on? Where are they going elsewhere? And we're also making sure clients are able to follow up. We were finding on some of our 3-month follow-up calls that we were doing, clients weren't aware that they're supposed to keep coming back. They did have an appointment. We did call to remind, but it's that kind of disconnect. So just make sure that they're always aware that they're supposed to keep coming back. And then for us, we always look at our clinic accessibility and our client demographics. So make sure we're in the right spot for the populations we want to be serving. When we were in the East End, as well as when we were on the mountain, when we looked at the postal codes of our patients, they were actually busing from different areas. They weren't living near our clinic site. They just like the day and time of the week better than our other clinics. So really looking at where your patient's coming from and what best benefits them. And what we always like to say is work smarter, not harder. Really looking at how you can partner, how can you leverage what was already going on. So we had a great half day at the nicotine dependence clinic. We saw what they were doing, how we'd be able to modify that and implement that as well. We went out to some of your family health teams and saw your group and how you run that, and we've been able to modify that. So really making lots of partnerships, asking lots of questions, and partnering with those that are already doing the work. In 2008, our first year of clinic, we saw 36 clients. And 2018, last year, we saw over 300 clients for intense intervention. So we really feel that once you get it all in place, it will just keep rolling. And this is just going to be a little plug at our Hamilton Care Pathway. So like I said, we have 9 organizations that are stop sites. And when we do our healthcare provider training, we're not just trying to plug our clinic. We really want the patient to have that no wrong door approach so that they know where all the free places are within Hamilton, so that they know if they're part of a family health team that they can go there, that they know that if they identify as Indigenous or have a mental health diagnosis, that there's clinics specifically for them. So really looking at how we can work together to serve those 93,000 smokers and not just having it be one organization's problem. So I think I'm going to wrap it up there. I can see the chat's gone a little bit. So if you want me to start going through the questions and trying to answer here.
Hi, Megan. You can take that approach if that's best for you. You can just go through the chat box.
Sure. You're okay with that?
Yeah, of course.
Okay. So I think I see the first question being elaborating on nicotine replacement therapy off-label for pregnant and breastfeeding clients. Yep. So I am more than willing to share our medical directive. And so we've reviewed all the evidence that we were talking about in the first couple slides about looking at CanAdapt's guidelines and the other clinical guidelines. So first line of defense for a pregnant breastfeeding woman is motivational interviewing and behavioral support. If they're unable to quit with that, the second line would be short-acting nicotine replacement therapy. And then from there, your third would actually be using a nicotine patch. And that would be for 16 hours if they're pregnant and having them remove it at night so the fetus would have a break from the nicotine replacement therapy. So I can share that to make sure you do that. How does it work when you dispense nicotine large groups? Yes. So what we do is they come into the same boardroom. We actually give them numbers, so they get seen in the order that they come in. We adopted that from Stop on the Road, which we used to implement. And they all get a one-page sheet, and they're going to fill out their name, whether they're smoking, not smoking, the nicotine replacement therapy they're using. And then we also ask them, what are their triggers? What are they struggling with? What are they proud of with respect to quitting smoking? And what are their goals? And so they fill all that out, and we'll go in, we'll do a presentation. It's usually 10 or 15 minutes. Like I said, this week we talked about sleep and quitting smoking. We remind them how to properly use nicotine replacement therapy. Usually we'll talk about when their next appointment is. If some of them are due for follow-up surveys, we'll remind them of doing that. If we've flagged it in the computer and we know, especially if there's no email address, we'll ask them if they want to quickly do it with us at the end of our group session. And then afterwards, they're in a big boardroom and we just kind of go 1, 2, 3. It's not completely confidential. We do try, and it's more generalized. If people need more confidential appointments than that, we will book them into individual sessions. And yeah, from then we just book them back either in 1, 2, 3, or 4 weeks, and then we give them a baggie of their nicotine replacement therapy and they're off. So usually all of that takes an hour. If we are seeing the full maximum 20 people, it is a little bit of a running show, and sometimes it takes a little bit longer than that, and it means we are actually inputting those visit forms in the CAMH portal on our lunch break. But usually we can get through it, and it's pretty manageable. Okay, so the next question, do you ever have peer workers involved in any of your group sessions? We do not. That is a good suggestion, and we know that one of our sites in Hamilton, the Good Shepherd that works with mental health, they do use peer support workers, and they are doing that model. With our immigrant newcomer clinic, there are volunteers that provide language support, and they're out in the community, so there's more of a peer model working that way. We just have quickly went from individual counseling to group as well as individually, and we haven't kind of thought of having peer workers in yet, but if somebody has suggestions, we'd be willing to look at that. Okay, so the next question from Rosemary is evening appointments. That is a very good question. We get asked that a lot. We, over the years, have kept track of those requesting evening appointments. We used to quarterly offer an evening appointment because we are only Monday, 9 to 4, and the numbers were way too low. So it'd be the same as if somebody in the East End was offering. So unfortunately, we're not able to do that. We do try to brainstorm with them how else they can receive services, but our services are only during the day, unfortunately. Are you receiving referrals from telehealth? In theory, yes. I haven't pulled our referrals lately to see where they've come from because it's only been a month. We have had a meeting with Adam Jones from telehealth to talk about that, so hopefully we are. We do make sure we're still on the quit map. I guess in the next little bit we'll know whether or not telehealth is still referring to us. We used to get a lot from Smokers Helpline. Yes, and then so our clinic is open to everyone. They don't have to have an addiction. So nicotine is an addiction, and that's how we go through there. Our clients that are already part of alcohol, drug, and gambling do get first priority. All of our social workers are trained to do all the intake and registration forms with them, but our organization's policy is that social workers can't dispense, so they would then see us as a nurse, but anyone can attend our public health clinic. They don't have to already be part of our addiction agency. And then that answers the next question. Yes, so social workers are at our health unit. We have, I think, around 8 of them that are actually trained, and they will do the intake, and we try to make anything work. So if we do have somebody attending a group program that's always Wednesday nights, then we do work with that social worker to make sure the patient is getting the nicotine replacement therapy through their group, through that social worker at night. And usually what happens is I'll do a telephone assessment with them earlier in the week and just make sure that they've got all the health teaching that they need and I've got the right dose of nicotine replacement therapy for them. And then, so how do we fill out all the forms? So our first individual, we have the patients fill out their forms themselves. So we have about 20 people or 20 spots, and sometimes we fill that up. But honestly, on average, we have 8 to 10 people that will come to that session. And from that, we'll offer support. We'll have 2 nurses as well as a secretary there. So we'll offer support if they need help filling out the paperwork. And then the admin person will stay, and sometimes the 2 nurses will just enter it all into the portal. And then how we do the visit forms is we have subsequent visits the visit forms is that modified form that I was talking about, and we enter it after the person has left. We always know who's coming to group, so we look up how many weeks left they have before we see them. We make note of anything that was in the visit note from the previous time, and then we try to make note if they have a follow-up survey due. And yes, our medical directive covers anyone 12 and over, and I think we've seen maybe one 15-year-old and a handful of 17-year-olds. So the sky's the limit, but really we're not seeing anyone at that time, and we've seen very few people that are currently enrolled in school that would need time outside of that. A few of them have been downtown school, so they just come to us on their lunch break. And that would be one of our populations that we would see individual only. So we would not put a youth within a group program. So we would see that person individually, and all their follow-up would be individual appointments. Same with if somebody has a fear of social settings, we would make sure that they're in individual. So we want to tailor to what works for everyone. We're not just about seeing the most amount of people possible, but we also want to be conscious of not having a wait list, that if you're ready to quit, you really want to see someone within that first 2 weeks of that referral in order to get going and not wait. The one-page form we're using in group, yep, I can share that. Peer workers. Oh, yes. So peer workers, so we have had previously clients that have successfully quit come back and talk about their journey. We've had some really well-spoken people throughout that have been quit, and we're finding that when we are in that group setting, it works really well for those people starting out to see those people at the end that have successfully quit, that have done well. It's sometimes hard when you're starting out and you have a few people that never successfully quit, and we're telling them they've reached their 26 weeks of nicotine replacement therapy. So that is the other side of it, that it does make it hard for those new individuals that are starting within group. How are we managing clients who only vape? Okay, so vaping is not covered under nicotine replacement therapy for STOP currently. So if they are only vapers, we are referring them to telehealth. If they are a young adolescent, we are referring them to Alternatives for Youth, which is a program here in Hamilton that will counsel for vaping. If they are dual user, we are kind of fumbling our way through, trying to attend every webinar. Dr. Selby did send out something through the Teach listserv recently with some guidelines. But we don't see too many people right now that are dual users. And yeah, if they're only vaping, we're not seeing them in our clinic. We're not enrolling them. And then in Hamilton, the family health teams will only provide services to rostered patients. But because we have the largest family health team in Hamilton, as well as another very large two-site family health team, I think we estimated there are about 230,000 patients within our like 580,000 population. So they do have many of the rostered patients within Hamilton. And I think, from what I can see, that's all the questions within.
I think that addresses most of them. Thank you so much, Megan, for that very informative webinar and for highlighting all your hard work and success with your clinic. I really appreciated that. And thank you to everyone who attended. The chat box was very engaging with lots of questions. This webinar has been recorded, and I will be distributing the slides and a link to the recording so you can share it with your colleagues. Remember, a link to the evaluation and post-learning assessment will be distributed this afternoon, and you'll have 1 week to complete it if you would like a letter of completion. And if you participated as a group, please make sure that you email teach@kmh.ca with a complete list of participants by 2 p.m. today. And our next educational round webinar is actually next week. Sorry for the short notice. It is on Tuesday, November 12th, and presented by Dr. Peter Selby. And it will be on addressing modifiable risk factors to improve smoking cessation outcomes in the STOP program. And the registration is open, so you can register for that and look forward to it. And again, if you have missed the beginning of today's presentation, you would like to view it again, or you are interested in seeing previous Teach webinars, a link to our archived webinars is found on our webpage, so you can view them there. Thank you, everyone, and have a great rest of the week.